Hello, everyone, and welcome to today's edition of Podcast. Today is Tuesday, 9th of July, 2024, and I'm Rifat Mannan in California. We are continuing with our hematopathology lecture series, and this is going to be the 8th lecture in this series of talks on hematopathology. And we are delighted to welcome back Dr. David Cassarino, who is consultant dermatopathologist, and he's a very renowned dermatopathologist. So he works at Southern California Permanente Medical Group in California. And today he is going to give a talk on cutaneous B-cell lymphomas. And his last lecture was on cutaneous T-cell lymphomas. And at this time, I want to thank Dr. Aaron Orbach for really helping us in organizing this hematopathology lecture series. And thank you, Dr. Orbach, for your help. And thank you, Dr. Cassarino, for joining us today. And to our viewers, those who will be joining us or who are online, please feel free to post your comments or questions on Facebook and YouTube chat windows, and we will pass on to Dr. Cassarino at the end of the talk. So over to you, Dr. Cassarino. Thanks again.
Okay, thank you very much. Appreciate you inviting me to give this talk and having me back again after giving the T-cell lymphoma talk in April. So if you guys haven't heard that talk, you're welcome to go on to Facebook or YouTube at Pathcast. You can see the address here on the title page and look at those or that previous lecture, plus all the other hemopath lectures if you're interested. But I'm a dermatopathologist, not a hematopathologist, so I'm only going to be talking about cutaneous lymphomas. And today we'll be talking about B-cell lymphomas. So I'll stop my video now and start the lecture. So cutaneous B-cell lymphomas are not as large a category as T-cell lymphomas. The vast majority of cutaneous lymphomas are T-cell lymphomas. But in general, just very brief, some issues with cutaneous lymphomas in general, very scant lymphoid infiltrates such as early mycosis fungoides can be malignant. Very dense, nodular, deep infiltrates can be reactive, so-called pseudolymphomas, which are more in the differential diagnosis with B-cell lymphomas that we'll talk about today, can actually be benign. So things that can look very bad can actually be benign, and vice versa. Things that can look very subtle and almost completely benign looking can actually be early stages of malignancies. So hence, cutaneous lymphomas can be very difficult. You don't want to undercall things that may actually be lymphoma, but you don't want to overcall things, on the other hand, that are benign, even when they look pretty atypical. So a lot of times we need clinical pathologic correlation, especially early mycosis fungoides, things like lymphomatoid papulosis versus MF or ALCL. The clinical history, the description, number of the lesions is actually very important and can actually make the difference between some of those diagnoses. And also the classification of these systems, of these lesions changes, and there's different classification systems now. As you probably heard from Dr. Auerbach and other hematopathologists, there's both the WHO and the ICC. Luckily, when it comes to cutaneous lymphomas, there's really not much differences between them. So this is actually a nice recent review article if you're interested in looking up, kind of a summary of both the WHO and the ICC and, comparison of them. And they do go through the individual entities and the few differences between them. Today, again, we're going to be talking about B-cell lymphomas, so really just this bottom quarter or so of the table here. And really the only main difference you'll notice here is between primary cutaneous marginal zone lymphoma in the WHO, and the ICC actually calls it primary cutaneous marginal zone lymphoproliferative disorder, LPD. And it is a subtle but perhaps important distinction because actually marginal zone lymphomas are extremely low grade and almost essentially benign clinically. So the LPD designation may actually make more sense than calling it a lymphoma when 95, even 100% of patients in some studies have pretty good long-term survival, even with these primary cutaneous marginal zone tumors. All the other entities are basically the same, and we'll, again, talk about these. I'm not really going to talk about the EBV mucocutaneous ulcer or, these inborn errors of the immunity-associated lymphoproliferative disorders. And some of these reactive things are included in the WHO, but not in the ICC, but these are really, reactive or so-called pseudolymphomas, not true lymphomas. So that's probably why they're not included in the ICC. But approach to cutaneous lymphomas in general, whether it's a B or T cell lymphoma, again, clinical history, number of lesions, the appearance of the lesions, say they're small, papular versus larger plaque or nodular lesions can be important. Lab values like HTLV1, which is important for ATLL, EBV for EBV-related lymphomas, anemia, white blood cell counts for things like leukemia cutis, which can be in the differential, hypo or hypergammaglobulinemia. All of those clinical and lab values can be important. Of course, previous history of lymphoma, if they're biopsy something that they're suspicious for involvement by systemic lymphoma, but they don't give you that history, obviously that makes our job as pathologists more difficult. So, hopefully your clinicians, if they know the history, give it to you. A lot of times they may not even know the history. There may be a previous, remote diagnosis, or it was done somewhere else and the patient doesn't tell them about that. So, sometimes it's not their fault, but other times they may know the history and you have to, call them up or email them or whatever your way of contacting them is to get more information, which, can be very important, like primary cutaneous marginal zone versus systemic marginal zone, or primary cutaneous follicle center versus systemic follicular lymphoma. If they have a history of a systemic one, you're not going to call it a primary cutaneous lymphoma in those cases. And of course, immunohistochemical molecular testing are essential for the diagnosis of most of these lymphomas. Again, we're going to be concentrating on the B-cell lymphomas in blue here, and they are much less frequent. So overall, only about 20% of primary cutaneous lymphomas are B-cell lymphomas. So we won't be talking about MF, LYP, and ALCL, which are more common, and about 80% of lymphomas overall. We're going to be talking about the 20%, which are primary cutaneous B-cell lymphomas, especially the small B-cell lymphomas like follicle center and marginal zone. And I showed these charts in the last lecture. So again, most of these things, especially the epidermotropic tumors and the subcutaneous ones, are T-cell lymphomas. And then in the dermis, kind of sandwiched in between, you have a mixture of both B-cell lymphomas here in blue and T-cell lymphomas and lymphoproliferative disorders in black. And we're, again, just going to talk about the B-cell lymphomas. So within the dermis, again, you can separate things into about half B-cell and half T or NK T-cell lymphomas. And we're going to be, of course, concentrating on the B-cell lymphomas. And these are the small cell lymphomas, which we'll talk about first. And these are actually much more common, lower grade, especially the first two. Plasmacytomas are really extremely rare. Most of those are actually primary cutaneous marginal zone lymphomas with plasmacytic differentiation. We'll talk about that later. And there are systemic small B-cell lymphomas involving the dermis, but these are all the small B-cell lymphomas. And then what about large B-cell lymphomas? So there actually are a lot more dermal-based large B-cell lymphomas than there are T-cell lymphomas. So in this category, there's more, but most of these are actually very rare, mostly systemic. So we're really just going to concentrate on the diffuse large B-cell lymphoma leg type. We'll talk a little bit about some of these other ones in the differential diagnosis, plasmablastic lymphomas, and LYG briefly after diffuse large B-cell lymphoma leg type. So again, primary cutaneous B-cell lymphomas are only about 20% of lymphomas in the skin overall. Pretty much, by definition, there should be no extracutaneous disease at the time of diagnosis, especially marginal zone follicle center, since they're low grade. Almost by definition, they don't have any systemic involvement, and they shouldn't develop any systemic involvement, at least for a long time. The diffuse large B-cell lymphoma leg type are much more aggressive, so they can have both primary or presentation in the skin, but also systemic involvement at the same time. But if the clinical presentation is with the leg or other skin involvement initially, then it's probably a primary cutaneous diffuse large B-cell lymphoma leg type, and not a systemic diffuse large B-cell lymphoma. But those are much more aggressive and tend to systemically spread. We'll talk about those in the second half of this talk. So the primary cutaneous follicle center lymphoma, these are low grade follicle center derived, germinal center derived B-cell lymphomas. So they're mature B-cell lymphomas. Notice the difference in terminology versus systemic follicular lymphoma. So if you say the words follicular lymphoma, you're basically saying it's a systemic lymphoma. If you say follicle center lymphoma, kind of a subtle distinction, but that implies it's a primary cutaneous. So follicle center cutaneous, follicular lymphoma, nodal or other internal organs involved by lymphoma. So by definition, these are primary cutaneous, usually but not always present in the head and neck area, and must by definition be confined to the skin for 6 months after diagnosis. So if they have lymph node or other involvement, then it almost by definition is a systemic follicular lymphoma, not a primary cutaneous one. And it is a different disease, so much better prognosis, different treatment. It can just be observed or use local, topical chemo or localized radiation therapy. 85, 90% of cases lack the BCL2 gene rearrangements, which are seen in most follicular lymphomas. So these usually, again, present in the head and neck area, usually single plaque or nodular lesion. They can recur, so about 35% of them recur, and only about 10% can spread, but usually it's limited to, one or a few lymph nodes. So widespread dissemination and death are very rare. So, less than 10% even in long-term follow-up. So very, very low grade, but it is considered a lymphoma. So unlike the marginal zone, which may be considered a lymphoproliferative disorder, follicle center are considered a true lymphoma, just very low grade. So they can be observed, they can use topical chemo, local radiation, systemic chemo only really for extensive or disseminated disease if it spreads out of the skin. And here's just a couple other clinical photos from patients we've had here over the years. So multiple, like nodular kind of plaque, almost reddish to purplish, plum colored lesions is kind of the clinical buzzword you'll hear for the appearance of a lot of cutaneous lymphomas clinically. So mostly on the scalp, head and neck area, but they can be on the trunk and other sites as well. Histologically, what do you see? So it's usually a dense dermal infiltrate, can extend into the subcutis, no epidermotropism, unlike MF and other T-cell lymphomas. The pattern can be nodular, diffuse, or a mixture thereof, so both nodular and diffuse. If it's purely diffuse, it can be hard to tell from a diffuse large B-cell lymphoma, and we'll talk about that in the differential diagnosis later. The follicles are not as well defined as reactive follicles, so they usually lack nice, well-defined mantle and marginal zones surrounding the germinal centers, usually have very few or no tingible body macrophages. There usually are a lot of follicular dendritic cells, so you don't see a loss of them in malignant follicles. You see kind of expanded but disorganized networks, so not as well organized, but there can actually be numerous dendritic cells on like CD21, 23 immunohistochemical stains. And it's a mixture of mostly smaller centrocytes, which are the small cleave cells, and then the larger centroblasts, which have more prominent nucleoli and usually multiple nucleoli, unlike immunoblasts, which usually just have one big central nucleolus. So at low power, you can see this kind of nodular to diffuse pattern. So this one's kind of, vaguely nodular, multiple nodular areas, maybe even a reactive germinal center here. But you can see it's mostly nodular, getting somewhat diffuse and infiltrative here. So, that would be suggestive of a lymphoma, especially a B-cell lymphoma. So a clue at low power is a Gren zone. So if you don't see any epidermal involvement and there's a thin Gren zone between the epidermis and the infiltrate, think about B-cell lymphomas or reactive. So probably not a T-cell lymphoma. Again, of course, there are dermal-based T-cell lymphomas, so you'd want to rule those out. But the most likely things when you see this pattern at low power are B-cell lymphoma versus a reactive or so-called B-cell pseudolymphoma. When you see something like this, very dense, diffuse sheets of cells that look pretty atypical even at low power, it's probably a lymphoma. And then you're kind of more in the diffuse pattern of a follicle center versus a diffuse large B-cell lymphoma leg type, which again, we'll talk about later. A little bit higher power is showing kind of ill-defined, irregular follicles, so you don't see nice, well-defined germinal centers with reactive mantle and marginal zones are kind of poorly defined, and by immuno, most of these would be BCL6 positive. And then on high power, you get a mixture of the small cleave cells, which are the centrocytes, and then some larger cells with a few nucleoli you can see here and there, which are centroblasts, and usually few or no tingible body macrophages. Here's another example, very large, kind of multinodular. This one does look, very much like reactive follicles. So you should be thinking like a pseudolymphoma, B-cell pseudolymphoma with reactive follicles versus a low-grade follicle center lymphoma. But it is very dense. It's very deep. It's so-called bottom heavy, right? You can see it going deep in the dermis and into the subcutis. And these were all strongly BCL6 positive on immuno. And on high power, you can see there's, very little, if any, mantle zone, maybe a thin rim of reactive cells here, which may actually be T cells on the CD3 stain, so probably not even a really good mantle zone, but it's just too big for a reactive germinal center, and it's just uniformly BCL6 positive. And here's the BCL6 showing nice, strong, diffuse nuclear staining. So that's a primary cutaneous follicle center lymphoma involving the deep dermis and subcutis. And on high power, just another view here showing the cleave centrocytes. So these are smaller, more hyperchromatic, and then the centroblasts are larger, kind of more vesicular chromatin with bigger nucleoli. So a mixture of centrocytes and centroblasts for follicle center lymphoma. And I've highlighted the most important ones in yellow here. So MUM1 is a pertinent negative to rule out diffuse large B-cell lymphoma, either systemic or leg type, both of which are usually MUM1 positive. But BCL6 is the most important positive marker. So CD10, in my experience, and I think a lot of dermatopathologists will tell you this, is often weak or negative in the primary cutaneous follicle center lymphomas. I did put plus or minus here, but it's probably negative minus, kind of like the BCL2. So both CD10 and BCL2 tend to be positive more in systemic follicular lymphomas, and especially if they're very strongly positive, I really favor a systemic follicular lymphoma, even without a history. I've had a few cases like that where I suggested it's probably systemic, and they did turn out to have lymph node involvement, and they were systemic follicular lymphoma. So usually BCL6 is strongly positive, CD10, BCL2 are weak or negative in the primary cutaneous follicle center lymphomas, and then all three diffusely positive in systemic follicular lymphomas. Of course, CD20, PAX5 are going to be positive any B-cell lymphoma, so they don't help you too much. MUM1 negative, again, to rule out diffuse large B-cell lymphoma, including leg type. You don't really have to do molecular. I know, probably heme-paths do a lot more than dermatopathologist, but, if you have the clinical, the histology, and the immuno, in most cases, I don't think you have to do molecular. And if you did, B-cell gene arrangements, they're usually positive, but the T1418 for BCL2 translocation typical of follicular lymphoma is only positive about 10% of cases. The literature is kind of all over the map, actually, anywhere from like 5 to 40%, but the higher numbers were in the older literature. Most of the recent papers are actually around 8 to 10%. So most cases lack the T1418, which is typical of systemic follicular lymphomas. But with newer techniques, with RT-PCR, it's probably about 80, 90% positive for clonal gene rearrangements. And then by gene expression profiling, it shows germinal center differentiation, similar to germinal center like large B-cell lymphomas, which is probably not surprising. So here's just another example by immunohistochemistry, follicle center lymphoma. You see these nice large nodular areas, which could look like reactive follicles, but then you see all these diffusely infiltrative areas, which are CD20 and BCL6 positive. So not just reactive germinal center staining with BCL6, but diffusely infiltrative cells throughout the dermis. So that's consistent with a follicle center lymphoma, not reactive follicles. Higher power of some BCL6 showing more nodular areas here with germinal centers, but you can see how they're kind of irregular, branching. They're not like nice, circular, well-defined germinal centers like reactive follicles often show. And then here's a more diffuse pattern where it's just diffusely BCL6 positive, and those are often negative for CD10. Like I mentioned before, CD10 is often weak or negative, even in the pretty well-defined follicular lymphoma or follicle center lymphomas, but in the diffuse ones, it's almost always negative. So diffuse pattern of follicle center lymphoma, still BCL6 positive, but usually CD10, BCL2 negative. And then CD21, 23 usually do show numerous follicular dendritic cells. So they're there even when it's a diffuse pattern of follicle center. So we'll talk about marginal zone and diffuse large B-cell lymphoma later. So I'm not going to get into the differential so much with them right now. Just the other main thing in the differential is cutaneous follicular hyperplasia, or so-called, pseudo-lymphoma, and you can see this with reactive follicles in lupus, some drug reactions, infections, folliculitis, so ruptured cysts or folliculitis. You can sometimes see really exuberant reactive lymphoid infiltrates, including reactive follicles with germinal centers. And here's a nice reactive one here. So you can see a nice polarized germinal center here with a mantle zone, and then kind of looks like a marginal zone surrounding it. So pretty well-defined, well-circumscribed reactive germinal center versus lymphoma here, pretty much a naked germinal center. You can see it just sitting in the fat, really no mantle or marginal zone. It doesn't look polarized compared to the one on the left here. Tingible body macrophages, more reactive or more numerous in reactive things, few or none in lymphomas. Again, mantle and marginal zones and reactive things. CD10 and BCL2, well, CD10 is usually strongly positive in reactive germinal centers. BCL2 should be negative in both. So again, the primary cutaneous ones and reactive follicles should be negative for BCL2. BCL6 will be positive in both. So BCL6 doesn't help you so much. BCL2, again, not so much, so since negative in both, but CD10, if it's strongly positive, would favor reactive follicle centers. Of course, no clonal gene arrangements by PCR and no translocations. And here's just showing you some of the reactive follicles here with CD20, CD21 highlighting the follicular dendritic cells, CD10, again, being strongly positive. So that would, actually go against the primary cutaneous follicle center lymphoma since they're usually weak or negative. And if they're positive, it's also not as well defined, right? So both CD10, BCL6 are highlighting a nice, circular, well-defined germinal center here. So that's good for reactive. And then BCL2 is negative in reactive germinal centers. If it was positive, again, that could be a systemic follicular lymphoma involving the skin. Okay, so that was primary cutaneous follicle center lymphoma. One of the main things in the differential, of course, if you're pretty much at a low-grade B-cell lymphoma, the main thing is follicle center lymphoma versus marginal zone lymphoma. And this is the most, second most common primary cutaneous B-cell lymphoma after follicle center lymphoma. Again, the WHO refers to them as marginal zone lymphoma or MZL, whereas the ICC refers to them as marginal zone lymphoproliferative disorder or LPD. And again, I kind of like that because most of these patients have an excellent prognosis. Again, 95, even 100% 5-year survival in some studies. So, very few of these patients get systemic disease or die of their disease. I will talk a little bit about a subset that's IgM positive that can be more aggressive, but even them usually don't, end up dying of their disease. It can have some systemic involvement, but it's also pretty low grade. But anyways, marginal zone lymphomas or lymphoproliferative disorders, again, can present in the skin, but that's only one subtype of extranodal. And there's 3 types of marginal zone lymphoma in general: extranodal, nodal, and splenic. Of course, we'll only talk about skin, which is one of the extranodal subtypes. Usually presents as a single plaque or nodule. Can be a couple lesions, but shouldn't be more than 2 or 3. If you start seeing multiple nodules, that's suspicious for secondary cutaneous marginal zone lymphoma. So a patient with a splenic or lymph node marginal zone lymphoma can get secondary cutaneous involvement. The primary cutaneous ones, again, excellent overall survival, 5-year survival greater than 95%. Treatment, kind of like primary cutaneous follicle center lymphoma, they can just watch it. They can do local excision, topical chemo, or localized radiation if they're just 1 or a few lesions. Marginal zone lymphoma can be associated with multiple potential underlying causes. So things like lupus, chronic inflammatory diseases have been shown to, at least in a rare subset of cases, progress to marginal zone lymphomas or lymphoproliferative disorders. Infections, especially Borrelia, but that's really only in Europe. There's really no proven association in the United States, as far as I'm aware, between Borrelia and marginal zone lymphoma. But in Europe, there is a stronger link between Borrelia and MZL. And you can apparently use antibiotic therapy to treat some of those lymphomas if they are related to an underlying infection. Of course, in the gastric ones, H. pylori, is strongly associated with the marginal zone lymphomas of the stomach. And, if you treat the H. pylori, the lymphoma can regress. So antibiotic treatment can be used for those. Small intestine may be related to Campylobacter. Chlamydia may be associated with ocular marginal zone lymphomas, but that's kind of more controversial. So back to the primary cutaneous ones, marginal zone lymphomas or lymphoproliferative disorders. What you want to see is a dermal-based proliferation of B cells. So, small but somewhat atypical B cells and just too many of them. So usually a predominance of B cells over T cells, although some cases can have more T cells and B cells that we'll get into. And the B cells expand the marginal zone, so they kind of have this pale to clear so-called monocytoid look to them, but also a lot of plasma cells. So things that look like mature plasma cells, but you can also have plasmacytoid B cells, and there's usually reactive follicles, and you can see colonization of them by the marginal zone lymphoma cells. Sometimes the reactive germinal centers may be absent, especially with a small partial biopsy. You may not see them, and you also usually have a mixed background inflammatory infiltrate with a lot of other cell types. So histiocytes, plasma cells, EOs, neutrophils are often seen in the background. So again, 2 components in marginal zone composed of the reactive follicles and the reactive background cells. So you do have a lot of reactive cell types in marginal zone lymphoma. So unlike follicle center lymphoma, where you would have malignant follicles, the follicles are actually pretty small, well-defined, like reactive follicles, which I showed you in reactive lymphoid hyperplasia. So you can have reactive follicles, which can be kind of deceptive because you can mistake them both for a reactive process and for like a well-differentiated follicle center lymphoma, but the malignant cells are actually, pretty much surrounding and sometimes infiltrating those follicles. So you have to think about marginal zone lymphoma and get the immunohistochemical stains to make the diagnosis. So the cells themselves are usually kind of pale to clear monocytoid B cells, usually a lot of plasma cells, and they can predominate. So some of those cases are probably, or were probably called plasmacytomas in the past, but are better defined as marginal zone lymphoma in most cases. You can see Dutcher bodies, which are intranuclear inclusions, Russell bodies, which are cytoplasmic inclusions in the plasma cells, and lymphoepithelial lesions, but those are rare in the skin, more seen in the GI. So here's a couple pictures of marginal zone. So similar to follicle center lymphoma, there's a Gren zone. So no epidermotropism, no epidermal involvement, pretty dense nodular dermal and even subcutaneous infiltrates. You can see this dense kind of nodular to sheet-like infiltrate present throughout the superficial and deep dermis. So follicle center lymphoma versus like reactive things should be the main things in your differential diagnosis when you see these patterns, here's an intermediate power view of a pretty dense nodular to sheet-like infiltrate, mostly lymphocytes and plasma cells. If you go on even higher power, and they're infiltrating collagen bundles or surrounding adnexal structures and blood vessels, but not really destroying them. So there's no adnexal or vascular destruction. These are, very low-grade B-cell lymphomas, so you don't really get any destructive features like you can see in some of the higher-grade lymphomas. And then here are some of the reactive follicles. You can see a nice reactive germinal center-like area with reactive mantle zone around it, and then the marginal zone is all of these areas, which are expanded by these small pale to clear staining cells. So these are the so-called monocytoid B cells. And of course, I'm showing you like classic textbook examples. A lot of times in real life, they're not really this obviously pale to clear. They're just kind of small B cells, and too many of them. Plasma cells, though, are often prominent. So both true plasma cells and plasmacytoid B cells are very common in marginal zone lymphoma. And here's just an example showing you the Dutcher bodies in the plasmacytoid cells. So intranuclear immunoglobulins are Dutcher bodies. Russell bodies are the cytoplasmic ones. And here's, again, showing you reactive follicles, which are mostly not colonized. And then here's a follicle that's kind of being eaten up by the marginal zone. So they can surround the reactive follicles, or they can actually infiltrate the reactive follicles in some case of marginal zone lymphoma. So that's molecular colonization on the right. Lymphoepithelial lesions, so if you see them, that's great. It's definitely a clue to the diagnosis, but unfortunately in the skin, they're usually not there. So it's, almost never epidermotropic, but you can occasionally see a few B cells invading into adnexal structures. But again, it's actually not very common in the skin. It's much more in the GI, so stomach, small intestine, large intestinal marginal zone lymphomas, you're much more likely. And this is actually a gastrointestinal MZL here showing colonization by some of the B cells, and you can see the CD20 positive cells, some of them sitting in the middle of those glands. So again, that's a clue, but not very common in the skin. Immunophenotype of marginal zone. So unfortunately, there's not really a great specific marker for marginal zone lymphoma. In the skin, though, BCL2 is pretty specific. So for systemic small B cell lymphomas, BCL2 is positive in almost everything. So not too helpful in most systemic, like systemic follicular lymphomas, CLL, probably even mantle cell lymphomas can be BCL2 positive. But in the skin, remember, the follicle center lymphomas are usually BCL2 negative. So if you have a CD20 or PAX5 predominant B cell infiltrate that's mostly BCL2 positive, plus or minus CD43, so it's not as commonly positive BCL2, but if it's positive for BCL2 and 43, that helps you make the diagnosis of marginal zone. BCL6, of course, should be negative. CD10 should be negative, except for the reactive germinal centers. So you can see some BCL6 staining, but it should be pretty much limited to reactive germinal centers. You can see expanded dendritic cell networks by CD21, but they're usually more in the reactive germinal centers, not as diffuse as in follicle center lymphomas. And then besides BCL2, the most helpful immunostains are kappa lambda if they're restricted. So often, but not all cases, so probably more than 50–60% are clonal by kappa lambda, but then you have the other 30 or 40% of cases that are not restricted by immuno. So those cases you can do molecular on, but if it's clearly kappa or lambda restricted by immuno and it's BCL2 positive and it looks like a marginal zone, histologically I wouldn't necessarily get the molecular study. So kappa and lambda can confirm the restriction, and basically that's going to tell you that it is a clonal B cell or plasma cell population based on the kappa lambda. The heme paths probably do the IgG, IgM more often than derm paths do, but I think there probably is a tendency now to do IgM because it's rare, probably only about 10 or 15% of cases, but these so-called non-class switched IgM positive marginal zones may be more aggressive. So, most cases are really not that aggressive, but they do have more of a propensity for extracutaneous spread, whereas the usual IgG or IgA, so-called class switched, and those are most cases, like 85–90% of cases are IgG or a few IgA, IgG predominantly, or IgA. In a few cases, those are the so-called class switch, and those are the classic low-grade marginal zone lymphomas. Again, IgM, only about 10% of cases, but those may be more aggressive, and about 60% or more than 60% can also have mutations in the FAS gene, but I don't think that's something we commonly test for, at least not yet. So marginal zone lymphomas, again, usually a B cell predominance, but sometimes you can see more T cells than B cells, so those can be tricky, right? If you have more than 50% CD3 positive T cells, that can make it a little more difficult. So then, you have to look closely at the BCL2, CD43, kappa lambda, so you can have predominance of T cells, but if it's clonal, kappa or lambda, or the BCL2 is staining the B cells in addition to T cells, which are normally BCL2 positive, those findings would favor marginal zone lymphoma. Of course, sheets of B cells with fewer T cells is concerning for B cell lymphoma in general. If there's a mixture of B and T or more T cells, then of course, things like BCL2, kappa lambda, or PCR are more important to diagnose clonality. So here's just fairly straightforward example of marginal zone lymphoma: CD20 positive, CD3 negative, CD43 again, kind of like CD10 for follicle center lymphoma. It's usually negative in the skin, but if it's positive, that helps you. So if it's strongly CD43 and BCL2 positive, that favors marginal zone lymphoma, but a lot of cases in the skin are negative for CD43. So I usually don't get it unless the BCL2 is, not really great or still kind of iffy after the BCL2 kappa lambda. I'll add the 43, and if it's positive, that can also help favor marginal zone. If it's negative, it certainly doesn't rule it out. But most cases are going to be pretty much all cases are going to be BCL2 positive, and then some cases are going to be CD43 positive. So, the immunophenotype is not entirely specific for marginal zone lymphoma. You do see BCL2 on a lot of other things, including systemic B-cell lymphomas, which we'll talk about later in the differential diagnosis. But if you have BCL2 positivity and kappa or lambda clonality, and here's a nice example, you see, kind of deeply infiltrative nodular aggregates of cells throughout the dermis. These are CD20 positive, a lot of plasmacytoid and plasma cells on high power, and these were like all kappa. So you can see some weak, probably just background lambda staining here, but basically no lambda staining here and very strong kappa staining. So clearly kappa clonal, like 100-to-1 ratio. So in a case like that, you don't have to do molecular, it's clonal kappa expression. So that's marginal zone lymphoma. The main things in the differential are reactive and primary cutaneous follicle center lymphoma, which we already talked about. One of the other things in the differential, but much, much more rare, it's kind of like the MFH of lymphomas, how MFH has gone away, and we refer to those as pleomorphic sarcomas these days. Cutaneous plasmacytomas has mostly gone away as a diagnostic term because probably the vast majority of those are really just plasmacytoid marginal zone lymphomas. So most cases previously diagnosed as plasmacytoma in the skin really probably were truly cutaneous marginal zone lymphomas, but there probably are very rare cases of true, plasmacytomas, single lesion, really, exclusively derived from plasma cells, no other lesions, no, really background of a more expansile B cell infiltrate that's BCL2 positive. So it's really a purely plasmacytic infiltrate. You could perhaps call it a plasmacytoma, but then I would, strongly recommend clinical correlation workup with serologies because, some of those may actually represent, a systemic B or plasma cell lymphoma or multiple myeloma. So about 20% can have monoclonal gammopathy or can have underlying bone marrow involvement with lytic bone lesions. So those are multiple myeloma, basically. So you can see something that looks like a plasmacytoma in the skin, but it could represent a manifestation of underlying multiple myeloma. Here's one that was just a single lesion clinically, and it was a very dense, almost all plasma cell infiltrate histologically, so it has a Gren zone, just like marginal zone, follicle center lymphoma at low power, no epidermal involvement, surrounding but not destroying the adnexal structures, just like marginal zone lymphomas, but pretty much all well-differentiated plasma cells. They're usually not dysplastic looking. If they are more atypical or dysplastic looking, then you definitely want to think about like a lymphoplasmacytic lymphoma, plasmablastic lymphoma, multiple myeloma, some more of the aggressive systemic plasmacytic tumors, which could just, be involving the skin. And of course, you can see Russell bodies, Dutcher bodies, which are cytoplasmic and nuclear inclusions from the immunoglobulins. And plasma cells usually show that eccentric nucleus, that perinuclear Hoff from the Golgi apparatus, and the so-called kind of clumpy clock-face chromatin, usually inconspicuous nucleoli and abundant or fairly abundant eosinophilic staining cytoplasm. So remember, plasma cells versus the B cells. B cells are positive for CD45 and 20, but plasma cells are negative for those markers, whereas they're positive for CD38, CD138, MUM1. So even benign plasma cells are usually MUM1 positive. So that's why you can see some MUM1 staining in marginal zone lymphomas with plasmacytic differentiation. But you want to be careful not to call that a diffuse large B cell lymphoma. So both normal and neoplastic plasma cells can express MUM1. CD56 actually, in contrast, unlike normal cells, that's usually only a neoplastic one. So 138 MUM1 will stain plasma cells in general. CD56 more neoplastic plasma cells. So if it looks like a plasma cell rich infiltrate, but you're between reactive and neoplastic, like a marginal zone lymphoma or plasmacytoma, versus a reactive infiltrate, the CD56, and of course kappa lambda will help you in that differential diagnosis. But 45 and 20 are going to be negative. So, like a marginal zone lymphoma or plasmacytoma, if you start out with just CD3 and 20 and not kappa lambda, you're going to miss, all the plasma cells because they're going to be CD20 positive. So if it looks like there's plasma cells histologically, and the differential includes a B cell or plasma cell neoplasm, I'll always get 320 kappa and lambda all, to start off with in the evaluation for lymphoma. So here's another plasmacytoma here. You can see pretty much all exclusive plasma cells, eccentric nuclei, clock-based chromatin, Golgi apparatus kind of surrounding some nerves and blood vessels, but not destroying them. And this one was lambda restricted. So, plasmacytomas are usually going to be very obviously kappa or lambda restricted by immunostains. All right, so that was probably more than half because, again, primary cutaneous follicle center lymphoma and marginal zone lymphoma are the two main B-cell lymphomas that you should be aware of in the skin. I do want to briefly touch on some systemic B-cell lymphomas because these are in the differential diagnosis, right? With follicle center lymphoma, there are systemic follicular lymphomas you want to rule out. With marginal zone lymphoma, there are systemic marginal zone lymphomas you want to rule out. And then, of course, there's other things like mantle cell, which is much more aggressive, CLL, which can involve the skin, actually does involve the skin very frequently for CLL. Mantle cell really only very rarely involves the skin, but obviously much, different clinical prognosis. These are by definition systemic B-cell lymphomas. So if they're involving the skin, it's, going to be a much worse prognosis. If they haven't been diagnosed before with a systemic lymphoma, you can make the initial diagnosis based on a skin biopsy. So, they have underlying systemic involvement, but sometimes it hasn't been discovered and they can present with skin lesions. So I've definitely seen cases like that where systemic follicular lymphomas are first diagnosed based on a skin biopsy. I know we don't have, people are muted so you can't reply, but if you were here or I could hear you, I'd ask you what this most likely is. You can see a Gren zone here, no epidermotropism, so probably a B-cell lymphoma, right, or reactive, but I'm not going to show you a reactive thing right now. So strongly CD20 positive, CD5, CD23. So that's pretty classic immunophenotype for CLL, SLL, right? So 5, 23, 43. BCL2 are all usually positive in CLL, SLL. So this was a patient with known systemic CLL involving the skin. And again, CLL is very common in the skin. So if they have known active disease, if you get a biopsy for basal cell carcinoma, don't be surprised to see CLL involving it. And it's almost like an incidental finding. If they're in remission, on the other hand, and you find CLL in a biopsy for basal cell or something else, then of course it's important. I mean, either way, I'd report it just to, document it. But, if they're in remission and they have CLL in a skin biopsy, obviously that's important because they're not in remission anymore. But anyways, that's very common in the skin. So of the systemic lymphomas, I'd say CLL, SLL is the most common that we see in the skin. And remember, those are 5, 23, and 43 positive. Of course, 5 can be positive in other things like mantle cell, 23 can be positive in, I think, a subset of marginal zone lymphomas, even some follicular lymphomas rarely can be CD23 positive. So none of these markers are entirely specific, but if they have a history of CLL and it's 5, 23, and 43 positive, it's probably CLL. Burkitt lymphoma, I don't think I've ever seen the skin, but those are usually BCL2, CD10, BCL6 positive. Systemic follicular lymphomas, remember, usually CD10, BCL2 positive, BCL6, of course, positive, but that's not going to help you versus the primary cutaneous one. Mantle cell lymphoma, again, very rare in the skin. I've probably only seen like 2 cases in my career, but those are strongly cyclin D1 positive, and since they are aggressive lymphomas, they usually do have a known history of systemic mantle cell lymphoma. Before they present with skin involvement. Systemic marginal zone lymphomas, pretty much like the primary cutaneous ones, are BCL2 positive, can be kappa or lambda. I don't have those on the chart, but usually CD23 negative, CD43 positive. MUM1 again can be positive, but only in the plasmacytic cells, so it's not like diffuse large B-cell lymphoma where most of the tumor cells are strongly MUM1 positive. So that's kind of just a comparison of the different systemic B-cell lymphomas and their immunophenotypes. Here's an example of systemic follicular lymphoma involving the skin. So I talked about these earlier, but just, to repeat, BCL2 and or CD10, if strongly positive, should really strongly raise suspicion for systemic follicular lymphoma, because the primary cutaneous ones usually are weak or negative for both BCL2 or CD10. Translocation 418, where the BCL2 gene is relocated, also should strongly raise suspicion for systemic follicular lymphoma. And here's one that did involve the skin, but also was involving the lymph nodes and bone marrow, so those systemic involvement. So CD10, BCL2, again, both very strongly positive in systemic follicular, usually weak or negative in primary cutaneous ones. And pretty rare, again, some of the earlier studies showed higher rates of positivity, but probably only about 8 to 10%. I just saw two pretty recent papers that both were right around 8% of primary cutaneous follicle center lymphomas showing this translocation. So pretty rare. And, if you're favoring primary, I probably wouldn't even get the translocation, because if anything, it's just going to be misleading. So based more on, this BCL2, CD10 staining, you can help to differentiate the primary cutaneous versus systemic follicular lymphomas. And, just going through the differential diagnosis again, we just talked about marginal zone lymphoma. We'll talk about the leg type next under the more aggressive B-cell lymphomas. So this is mostly for the comparison of primary cutaneous follicle center versus systemic follicular lymphoma. So the clinical can actually look pretty similar, multiple plaques or nodules. Of course, they are a much higher stage if they're systemic, but histologically, they can be pretty much identical looking, so follicular and or diffuse patterns. The follicles, of course, are malignant. They're both going to be BCL6 positive, but BCL2, CD10, again, if strongly positive, would favor systemic follicular. Again, both would be monoclonal, but the T14/18, only few of the primary cutaneous, but much higher percentage of systemic follicular lymphomas. And of course, these are treated much more conservatively versus systemic follicular lymphomas, which are going to be treated with systemic chemo. So the differential diagnosis by immuno, again, just focus on the primary cutaneous follicle versus systemic follicular lymphoma. So both, of course, CD20, BCL6 positive. The CD10, BCL2 are really the ones that are going to help you distinguish them. So again, weak or negative for both. And the primary cutaneous, strongly diffusely positive for both, usually in systemic follicular. MUM1 should be negative in both of those, by the way, and positive in the leg type lymphoma, which we'll talk about next. So we've gone over the small, medium-sized B-cell lymphomas. Now we're going to talk about the large cell lymphoma. So I'll briefly touch on a few of these other ones, but really concentrating on diffuse large B-cell lymphoma leg type, which is, not nearly as common as marginal zone or follicle center, but more common than any of the other more aggressive B-cell lymphomas that can involve the skin. So these usually, but not always, occur in women on the lower leg. So, of course, they can occur at other sites and in males. And actually, I was kind of hoping that the WHO would drop the leg type, because it, just feels kind of dumb saying diffuse large B-cell lymphoma leg type when it's on the nose or the chest. You're calling it a leg type lymphoma. So why not just call it primary cutaneous diffuse large B-cell lymphoma? Whether it occurs on the leg or another site, it's a primary cutaneous diffuse large B-cell lymphoma. But anyways, we're still stuck with this name. So leg type is still in the WHO and the ICC. Usually they present on the legs, so probably 80% or so of the cases present on the lower extremities. Again, usually elderly females. One or more plaque or nodular lesions, a couple of kind of subtle, almost little hyperpigmented looking lesions here, and then smaller nodular lesions in some of the other ones, but they're usually pretty aggressive looking clinically. So they might start off as papular, but then rapidly, grow into plaques or nodular lesions, and they are much more aggressive than other primary cutaneous B-cell lymphomas. So they often disseminate. So even though they present in the skin, they often disseminate and have less than 50% 5-year survival. So these patients do need, very, strong workup for systemic involvement. So even starting in the skin, they usually spread, and they need systemic treatment with chemo, radiation therapy. And these are usually, frankly, malignant. So unlike marginal zone, follicle center, or often between reactive and a low-grade lymphoma, these are just, in-your-face malignant tumors to begin with. Sometimes I even think about Merkel cell carcinoma, metastatic small cell carcinoma, even melanoma. There are small cell melanoma. So when you first see something like this, you really should think of malignant, basically blue cell tumor. I don't really want to say small blue cell tumor, because these are not small, at least when it comes to lymphomas, but you do want to think about small cell carcinoma, Merkel cell carcinoma, even melanoma, other primary and metastatic tumors. So when you see something like this, it may be hard to think about diffuse large B-cell lymphoma initially, but your panel probably should include at least a CD3 and a CD20, and if they're strongly 20 positive, then you can get the other markers like BCL2 and MUM1. So they can be very malignant looking, but tricky to identify, at least initially, as lymphomas. This case here on the left did have a Gren zone, didn't involve the epidermis, so you could think about a B-cell lymphoma versus things like metastatic tumors, but on high power, this one actually has, what look like lymphoid cells, so they're very atypical, hyperchromatic, pleomorphic looking, some mitoses, but they are very round and they're kind of standing apart, unlike a carcinoma like Merkel cell carcinoma, where the cells are more cohesive. Another example here showing prominent immunoblasts, so not really the centroblasts you see in follicle center lymphoma, but immunoblasts with big prominent central nucleoli. You can see a few centroblasts and or immunoblasts, but really no centrocytes, which are the smaller cleave cells that you see in follicle center lymphoma. Of course, no epidermotropism. And the immunophenotype is often BCL2, MUM1 positive. So both of these are usually very strongly diffusely positive. FOXP1 is also usually positive. So I think of that as similar to MUM1. So it's not really specific for the diffuse large B-cell lymphoma leg type, but most aggressive, even systemic diffuse large B-cell lymphomas are positive for MUM1, FOXP1. So they both kind of correlate with more aggressive phenotypes. BCL6 is often positive as well. So if you see the combination of BCL2, BCL6, and MUM1, that favors diffuse large B-cell lymphoma leg type and not primary cutaneous follicle center lymphoma. So despite the BCL6 staining, which could be consistent with the lower grade follicle center lymphoma, the strong BCL2 and MUM1 are not really consistent with that. And then you could also do CD21, CD23. Those should be negative, unlike in the follicle center lymphomas. And then there's multiple translocations like MYC, BCL6, IGH, MID, MYD, 88, and CD79. So, the actual gene for CD79, these can also be mutated. And I think these are common in the skin, maybe the breast and a couple other sites, but most systemic diffuse large B-cell lymphomas, at least the couple studies I've seen, are negative for these mutations. So these mutations are not entirely specific, but more common in the skin and a few other sites, but not so much as systemic diffuse large B-cell lymphomas. And of course, no BCL2 translocations, which are typical of follicle center and more follicular, systemic follicular lymphomas and some systemic large B-cell lymphomas. So here's the immunophenotype of diffuse large B-cell lymphoma leg type. So PAX5, CD20, of course, are going to be positive in any B-cell lymphoma, but the strong BCL2, MUM1, and BCL6, and again, all three of these together is classic. The BCL6 is the one that can be negative in some cases, but the majority are positive for all three, and especially the BCL2 and MUM1 should be strongly diffusely positive. CD10 should be negative, 21, 23 should be negative for dendritic cells. And the main differential diagnosis includes primary cutaneous follicle center lymphoma with a diffuse pattern. So the diffuse pattern of follicle center lymphoma can mimic a diffuse large B-cell lymphoma leg type, and they can present on the legs in some cases, even though they're usually on the head and neck area. So here you can see a Gren zone, dense, kind of nodular to sheet-like infiltrate in the dermis, but on high power, there's actually a mixture of some larger cells, but they're not as frankly malignant looking as a leg type, and there's also a lot of these smaller cells, some of which look like the centrocytes, so not just a large centroblast and immunoblast of diffuse large B-cell lymphoma, but a mixture of smaller and large cells. So they can be difficult to tell, but you can have clues on the H&E and of course the immuno. So BCL2, MUM1 should be negative in the primary cutaneous follicle center lymphoma diffuse type, but positive diffuse large B-cell lymphoma leg type. And again, the clinical is very different. So most of these are going to be on the leg. Most of the follicle center are going to be head and neck, only rarely on the legs. 5-year survival. Obviously, the clinical prognosis and treatment are very different. So these are aggressive, often spread systemically. These are low grade, usually do not spread systemically. Morphologically, again, you can see diffuse areas in the primary cutaneous follicle center lymphoma, but there's usually, kind of a mixed pattern of follicular, looking areas, so kind of more nodular areas, which may have some germinal center differentiation on the H&Es, and diffuse areas, perivascular areas, and oftentimes fibrosis. That's actually kind of a often overlooked clue, but chronic, like low-grade B-cell lymphomas like follicle center or marginal zone, usually they've been there for a long time before they're biopsied because they're slow-growing. They don't come to attention clinically very often or, very quickly. So they may have been there for years. So there's usually a mixture of background reactive cells and stromal fibrosis, low-grade B-cell lymphomas, but you just don't have time for the fibrosis and usually don't have much of a reactive infiltrate in diffuse large B-cell lymphoma leg type. And again, the cells are larger, more round cells in follicle center. At least some of them are smaller, more cleaved cells. So a mixture of centrocytes and some centroblasts, whereas these are mostly immunoblasts and centroblasts. All right, and again, by immuno, I already talked about this. So the BCL6 doesn't really distinguish them, but if it's weak or negative, that would actually favor the diffuse large B-cell leg type. If it's strongly positive, but MUM1 and BCL2 are negative, that would favor follicle center. So again, BCL6 positive in both, usually more strong in follicle center, but BCL2, MUM1 should both be negative, whereas both of these are positive in diffuse large B-cell lymphoma leg type. So really, these three markers are the ones that are going to help you. CD10 is negative in the leg type, but again, a lot of the follicle center ones in the skin are CD10 negative, so I don't find that as helpful. So that's why I've highlighted the other three in red: BCL6, BCL2, and MUM1. So those are really the three that'll help you with the diagnosis. We don't have FOXP1, so I don't have much experience with it, but it looks like it's pretty similar to MUM1. So a lot of aggressive large B-cell lymphomas are often positive for FOXP1 as well as MUM1. So if you have it, or you want to get it as an outside immunostain, you probably could, but it usually goes along with MUM1. So leg type and other diffuse large B-cell lymphomas are often positive for MUM1 and FOXP1, whereas the primary cutaneous follicle center lymphoma should be negative for both of those. Here's just the BCL2, again, strongly positive in the leg type, negative in the follicle center lymphoma. CD21, 23, 35 will be positive in the primary cutaneous follicle center lymphomas because they have dendritic cells. So even the diffuse pattern, which can look like a diffuse large B-cell lymphoma, should still have dendritic cells. So those should be there in the follicle center lymphomas, whereas they're absent in the primary cutaneous diffuse large B-cell lymphomas. All right, so systemic diffuse large B-cell lymphoma versus a leg type can be very difficult to tell. So really the clinical history of systemic disease is key for the diagnosis because these can look and stain pretty much identical to diffuse large B-cell lymphoma leg type. If they only have tumors on the lower legs, or they started with tumors on the lower legs and then progressed to say lymph node or other organ involvement, that would of course favor the primary cutaneous diffuse large B-cell lymphoma leg type. If they started with lymph node or bone marrow or other internal organ involvement and then had skin, then obviously it's a systemic diffuse large B-cell lymphoma. So if you have the history, that can really definitively distinguish between them. And if you don't have the history, which is often the case, unfortunately, then it can be much more difficult. And of course, you have to recommend clinical correlation, imaging studies to try to distinguish them. There are these very rare primary cutaneous diffuse large B-cell lymphoma are not leg type. So really, if there's no classic features of leg type or follicle center lymphoma, there's no systemic diffuse large B-cell lymphoma, then it could just fall into this category of primary cutaneous diffuse large B-cell lymphoma, NOS. But I've really never made that diagnosis. So I think vast majority of the primary cutaneous ones are leg type, and then the other ones are probably systemic diffuse large B-cell lymphomas involving the skin. Here's just one rare example of a thymic large B-cell lymphoma, and of course the only way I was able to make this diagnosis was based on the history. The patient did have a known history of a primary mediastinal large B-cell lymphoma, which I think she had for like 3 or 4 years, and then she started presenting with skin symptoms, but she just presented with a skin nodule. You really wouldn't be able to tell if this was a primary versus systemic diffuse large B-cell lymphoma, and it was BCL2 and MUM1 positive, so just like the leg type. So really the clinical history is key in distinguishing them. A couple other less common ones. We're almost at the end now. But there are a couple other more aggressive B-cell lymphomas that can secondarily involve the skin. So there are plasmablastic lymphomas. I think I've seen maybe 1 or 2 of these involving the skin, and both patients were immunocompromised, HIV positive, or I think one was a liver transplant patient who actually rapidly died from the disease. So these are often aggressive lymphomas. They can present in the skin, but more commonly in the oral cavity, GI tract, usually immunocompromised, often HIV positive. So that's kind of the classic presentation. But in reality, they can involve any site, including the skin, not just oral cavity or GI tract. They can even present immunocompetent patients, usually EBV or about 50% EBV positive, mostly HHV8 negative, but some cases, there's more negative EBV cases, and occasionally HHV8 positive cases have been reported as well. So reality can be a little more complicated than the classic presentation of plasmablastic lymphomas, but these are very rare, aggressive, basically high-grade malignant plasmacytic lymphomas. So they look, like immunoblasts and plasmacytoid B cells, but really not, small, reactive-looking mature plasma cells. So really, frankly, malignant-looking plasmacytoid cells. So they look most like diffuse large B-cell lymphoma, but then you start looking at them on high power, and you get the impression that they have plasmacytic differentiation, big nucleoli, and a lot of B cells. But then again, a lot of the nuclei are kind of eccentric, a little bit of the clockwork chromatin, and then some of these actually have really nice plasmacytoid features. And these will actually stain with CD45. So unlike most, mature plasma cell neoplasms, like I talked about earlier, plasmacytomas usually are negative for 45 and 20. These can be positive for 45, but usually negative for 20. PAX5, CD10, of course, positive for CD38, 138, and EBV in situ hybridization. So again, a lot of them are positive for EBV, but plasmacytoid markers, MUM1 are usually positive. CD79A can be positive, and diffuse large B-cell lymphoma formerly of the elderly, they dropped that in the more recent WHO classification. So it's just EBV positive diffuse large B-cell lymphoma can look very similar, and of course are also EBV positive, but no history of immunodeficiency, unlike the plasmablastic lymphoma cases. And another aggressive, basically systemic B-cell lymphoma that you can see in the skin. So these are also rare, but I'd say more common than the plasmablastic lymphomas. I've seen probably a few more of these over the years. So they often involve the lung, but skin is actually the second most common site. So they are rare, but you can see them in the skin if you're doing a significant amount of derm path. So these are also EBV positive B-cell lymphomas, often angiocentric, angiodestructive. So they can look a lot like NKT cell lymphomas. So if you saw my first lecture, we talked about NKT cell lymphomas, gamma delta T cell lymphomas are more aggressive. T and NKT cell lymphomas can also be angiocentric, angiodestructive, but these are B cell lymphomas. So obviously the CD3, CD20 are going to help you distinguish them. So they often have a lot of reactive T cells, which of course are smaller, CD3 positive cells, but then larger atypical cells are CD20 positive B cells, angiocentric, angiodestructive, often fibrinous necrosis, and they're graded based on the number of EBV positive cells. So, grade 1, 2, and 3 based on the number of EBV positive cells per high power field. And here's an example I saw a couple years ago where you had a pretty, atypical, it's kind of patchy, actually, not really that dense, but definitely atypical infiltrate with a lot of vascular centric and vascular destructive features on high power. So it looks kind of necrotic in areas even at low power, and then when you go on high power, you can see the vascular destruction. So you can see that the necrosis is secondary probably to ischemic changes from the vascular damage. So angiocentric, atypical cells here, and then some angiodestructive features here on the right. And these are, again, CD20 positive, EBV positive cells. Gamma delta, NKT cell, obviously you can get the diagnosis because those will be CD20, PAX5 negative, CD3, CD2, CD56 for the NKT cells, CD3, positive for the gamma delta, also CD56 for gamma delta T cell lymphoma. So the EBV and the other immunos can help you distinguish LYG from T cell, NKT cell lymphomas, and then versus diffuse large B cell lymphoma leg type, which is usually not angiocentric or destructive. EBV is negative in those, so positive in LYG, negative in diffuse large B cell lymphomas, and of course vasculitis. You can see vascular destruction, but you really shouldn't see an atypical, B or T cell infiltrate. Of course, EBV should be negative, no clonality if you do clonal studies. And here's a CD20, so may not be very numerous cells, but the larger atypical cells are CD20 positive, PAX5 positive, and EBV in situ or EBER positive as well. So that was LYG. And very lastly, I was thinking about skipping this one, but since it's a shorter lecture, T cell lymphomas, I kept it in. These are very rare. I've seen maybe one or two of these. So again, something much less common than a lot of the other B cell lymphomas, but these actually do often involve the skin and or brain. So they'll even do random skin biopsies looking for these, which are of course usually negative. So they're kind of low yield, although there are some papers suggesting that they do multiple skin biopsies and maybe they'll get lucky and find some focal involvement. But these are very rare, basically systemic B cell lymphomas that are really only involving the blood vessels. They can be very subtle, like almost nothing apparent clinically, or they can present as papules, nodules. Of course, those are easier to diagnose because then they would biopsy an obvious lesion clinically. If there is involvement, it's usually superficial and deep dermal. Vessels can also be subcutaneous, so if they do a superficial biopsy, they might miss it. And these are basically intravascular diffuse large B-cell lymphomas, right? So large, atypical CD20 positive cells. And these, of course, are aggressive, basically systemic B-cell lymphomas. And here's a picture from the paper because I don't have any cases I've seen of this recently, but intravascular atypical B cells, which are PAX5, CD20 positive. I think they're probably MUM1 positive, EBV negative, but don't quote me on that. And here's just another picture from another paper showing diffuse involvement of a lot of the subcutaneous blood vessels. So again, they probably have to get multiple skin biopsies and go deep enough into the deep dermis subcutis to get the involved vessels in some cases. All right, so pretty much we're at the end now. To summarize, we've talked mostly about the low-grade B-cell lymphomas, so the two primary cutaneous low-grade B-cell lymphomas you want to remember. These are the ones you're going to see most frequently in day-to-day practice if you're doing any significant amount of derm path, or the primary cutaneous follicle center lymphoma, primary cutaneous marginal zone lymphoma. Plasmacytomas, again, are extremely rare. Most of those are probably just marginal zone lymphomas with plasmacytic differentiation. You may see some systemic B-cell lymphomas, especially CLL. So think about that, kind of in the back of your mind. Do CD5, CD23, if CLL is in the differential. And then for the diffuse large B-cell lymphomas, I did talk about some of these rare ones like plasmablastic, lymphomatoid granulomatosis, and intravascular B-cell lymphomas. But really, the main one you need to know is diffuse large B-cell lymphoma leg type. So if there's any residents out there, either derm or path residents, the three take-home ones you should know about are just follicle center, marginal zone, and diffuse large B-cell lymphoma leg type. Those are really the three main ones that you need to know, especially for the boards that they might test you on. And again, this is that paper I showed you guys in the beginning. I think this is a good, nice, recent, up-to-date article comparing and contrasting the WHO and the ICC. And again, really, when it comes to the primary cutaneous lymphomas, very few differences. The marginal, for the B-cell lymphomas at least, it's really just marginal zone lymphoma in the WHO versus marginal zone lymphoproliferative disorder in the ICC is a main difference. And then if you want to read more, especially if you're a practicing derm path and you're interested in learning more about some of the controversies and classifications of these, why they're calling things like small, medium, pleomorphic T-cell lymphoma, lymphoproliferative disorder, and marginal zone lymphoma, lymphoproliferative disorder now in the ICC. This is kind of a nice discussion of the lymphoproliferative disorders, both B and T cells. So that's a good recent article from the JCP if you'd like to read about them. And again, overall, the WHO and ICC classifications are very similar. So I don't think it really makes a difference which one you use. Probably the WHO is more common, and probably most people are using that. But again, only very minor differences, I think. And primary cutaneous lymphomas, lymphoproliferative disorders in general are very specific entities, usually, but not always, lower grade than systemic lymphomas. So makes a big difference for the patient, right, in terms of prognosis and therapy if it's a primary cutaneous versus the systemic B or T cell lymphoma. And obviously, clinical pathologic correlation, immuno and molecular studies are necessary in most cases to make the diagnosis, as I've talked about. And now I'll pause for any people have any questions. I guess we can.
Thank you so much, Dr. Cassarino, for this very comprehensive overview on cutaneous B-cell lymphomas. There are a few questions that I saw, which I have actually posted on a chat box. Can you see them?
Yeah. Hello from Thailand. I encountered one case of scalp nodule with dermal nodular infiltration by small B-cell lymphomas with few germinal centers. Standard results suggest reactive B-cell rich lymphoid proliferation, no kappa or lambda. Incomplete gene rearrangement. That sounds reactive to me. A reactive B-cell rich, but no kappa or lambda restriction. The PCR is not definitive. So it sounds like it's probably reactive. And again, marginal zone, lymphoma or lymphoproliferative disease is very, very low grade, so essentially reactive. So again, I kind of like the ICC designation of a lymphoproliferative disorder better. Primary cutaneous follicle centers are usually BCL2 negative, right? That's I talked about BCL2 positivity and ruling out systemic lymphoma morphologically. Um, yeah, so I mean, if you've ruled out a systemic follicular lymphoma, then I wouldn't really think you need to do the FISH. There are primary cutaneous follicle center lymphomas which can be positive for BCL2. So BCL2 or CD10 again tend to go along with systemic follicular lymphomas, but not all cases. So you can have primary cutaneous ones that are BCL2 and or CD10 positive. So I think that would be fine at least in some cases. Plasmablastic transformation or large cell transformation of primary cutaneous marginal zone. I've heard of that. It's definitely been described in the literature, but it's extremely rare. So I don't think I've ever seen a case personally of plasmablastic transformation or large cell transformation of primary cutaneous marginal zone, but it can occur. So very, very rare. Probably less than 1% of cases. But I think in those cases you'd need like a nice, well-known history of previous biopsies that showed marginal zone lymphoma, and then additional or later biopsies showing transition to a large cell plasmablastic or large cell B-cell lymphoma, make that diagnosis. And the last one, I have a question about intravascular large B-cell lymphomas classified in primary cutaneous mature B-cells. I think of those as systemic, right? Because they're in the blood vessels and they're usually involving the skin and the brain. So the blood vessels, in the skin and the brain are usually involved. So a lot of times they will have systemic symptoms like fever of unknown origin, fever, chills, night sweats, stuff like that. So, symptoms of a systemic lymphoma. I think there are some cases that have been reported to only involve the skin vasculature. So maybe there are very rare cases of only primary cutaneous intravascular B-cell lymphomas, but most of them are systemic. I would regard them as systemic, and usually they are aggressive.
So there was also another question, Dr. Cassarino. I saw that someone was asking about WHO versus ICC classification for primary cutaneous lymphomas. So I believe that you said something about that today, right?
Yeah, I talked about that in the beginning. Remember, I showed the chart, and at the end, I mentioned it again. Really, the main difference with the B-cell lymphomas is the marginal zone. So primary cutaneous marginal zone lymphoma in the WHO, and primary cutaneous marginal zone lymphoproliferative disorder in the ICC. So those are really, the two main differences. I can actually go to back to that chart. So these are all the T-cell lymphomas here, and actually there's really very few differences in the T-cell lymphomas or lymphoproliferative disorders. A couple terminology differences maybe, but really nothing significant with the T-cell lymphomas. And then with the B-cell lymphomas, here's the WHO marginal zone lymphoma versus marginal zone lymphoproliferative disorder. So I should have highlighted this in red or something, but really that's the main difference between the WHO and the ICC when it comes to primary cutaneous B-cell lymphomas.
There is another question, Dr. Cassarino. One of our colleagues wants to know about the relation between B-cell lymphoma and viral infection.
B-cell lymphoma and
viral infection.
Viral infection. Besides EBV, I'm not really sure about that. There are, EBV positive B-cell lymphomas, like I talked about, right? The EBV positive diffuse large B-cell lymphomas, which are usually systemic. EBV positivity is seen in lymphomatoid granulomatosis, and that's, almost definitional for that. The plasmablastic lymphomas are often EBV positive. There are systemic HHV positive ones, right? Like the body cavity effusion-related HHV positive lymphomas. But besides EBV and HHV, I'm not really aware of other viruses. I'm sure there are some, that are implicated, and nobody really knows what causes most cases of marginal zone and follicle center lymphoma. Maybe Borrelia, but that's only been shown in European studies, not in the U.S. So most cases of marginal zone and follicle center lymphoma, we don't know what causes them. It could be infection, it could be underlying chronic antigen stimulation, things like lupus and lichen planus, lichen sclerosis, occasionally, have been reported to lead to lymphomas like marginal zone. Small or subcutaneous paniculitis like T-cell lymphoma I talked about last time, that can definitely develop in lupus. So, there are some precedents for chronic, inflammatory diseases progressing to lymphomas, probably just because there's chronic antigen stimulation, a clonal population can develop in response to an infectious or an autoimmune stimulus, and then can just keep expanding, I guess, to eventually become a lymphoma. But that's probably a minority of cases. The majority, we don't know what is causing it.
So how often do you see Hodgkin lymphoma involving the skin? That is another question.
Very rare. I've never seen it. I keep hoping to see one, but yeah, it's extremely rare in the skin. So it's been reported. It can happen. You're much more likely to see LYP, by the way. So LYP is one of the cutaneous association with Hodgkin lymphoma. So if a patient has a known Hodgkin lymphoma and they have skin lesions, it's probably going to be reactive or LYP, not cutaneous involvement by Hodgkin lymphoma. And of course, CD30 would be misleading in that case, right? Because it's positive in LYP and in Hodgkin lymphoma, but then like CD15 and other B cell markers should be negative in LYP.
So one last question. I saw that if you see a follicular lymphoma in the skin, so do you try to make sure that this patient is not having a systemic follicular lymphoma? What is your approach? How do you go about it?
Yeah, well, yeah, like I mentioned, that's the main differential with primary cutaneous follicle center lymphoma is marginal zone lymphoma and systemic follicular lymphoma. So really, the immunostains can help separate it from marginal zone, and then CD10 and BCL2 can help you separate it from systemic in most cases. So again, BCL2, CD10 are both usually weak or negative in the primary cutaneous ones, usually strong and diffusely positive in the systemic follicular. But as one of the earlier questions pointed out, there are some cases of primary cutaneous that are BCL2 positive. I'm not sure if those are more likely to be CD10 positive or not, but you definitely can see a minority of cases that are BCL2 positive, some cases that are CD10 positive, but in my experience are usually weak or negative. So if the BCL6 is strong and diffuse, but the BCL2, CD10 are weaker or negative, that would favor a primary cutaneous. If they're all three strongly positive, that strongly suggests a systemic follicular. So I've even gone so far as favoring a systemic follicular lymphoma even without a history based on strong CD10, BCL2 staining, and those cases actually did turn out to have systemic involvement. So again, they're not perfect, but the immunostains can help you. But certainly clinical history, imaging studies, you can sign it out. So I usually kind of include a disclaimer at the end of my reports for both primary cutaneous marginal zone and follicle center lymphoma, saying something like, while a primary cutaneous lymphoma is favored, correlation with complete clinical and imaging studies is recommended for further evaluation and staging of this patient to rule out systemic B-cell lymphoma. So you can kind of come up with a canned comment, copy and paste that into the end of your report. So even if you favor a primary cutaneous, even a lot of the T-cell lymphomas, can favor a primary cutaneous one, but if it's not like classic MF or LYP or ALCL, well, actually ALCL, it's hard to rule out a systemic one. So you can kind of use that same comment if it's a T-cell lymphoma, but not clearly MF or LYP. You can also put in a comment that a systemic T-cell lymphoma should be, ruled out based on the clinical imaging studies and, that kind of workup.
I think that is good to know, because many a times the clinical information may not be available when one looks at the biopsies, and
Right.
especially for our colleagues who are working in different parts of the world, maybe they may not have access to the clinical information. So then adding a comment, I think, is a good suggestion, so that one can rule out.
That's definitely reasonable, especially if you don't have good history or you don't have, like a integrated healthcare system where you can go in and check the patient's history yourself. I would, either contact the clinician or, at least put in a comment that they need to work them up to rule out a systemic lymphoma.
Right. Thank you, Dr. Cassarino. I think these are all the questions that we had on Facebook and YouTube. And thanks to our viewers who joined from so many different parts of the world. Dr. Cassarino, you would be happy to hear that you had viewers who joined from different countries, including Peru, Mexico, Cambodia, Algeria, Kenya, Thailand, United Kingdom, and many enthusiastic residents. They joined from Jorhat Medical College in India. And thanks to all of you for joining us. And we have our next lecture that is coming up. So it is going to be a talk on neuropathology. So that would be on what is it called, July 30th of July, and we will have Dr. Fausto Rodriguez, so who is going to give a talk on interpretive consultation. I think that would be a very useful talk, as this is something that we face almost all the time. Like, and he is an expert on that. Hope that would be a useful session for all of you and for all of us. So thanks for listening, and please follow Patcast on our social media platforms, on Facebook, on YouTube and Instagram, as well as on X. And you have a QR code here, which you can scan so that you can get access to our YouTube channel. Thank you again, Dr. Cassarino, for joining us today. It was a pleasure having you.
Okay.
Thanks so much.
Thank you very much. Appreciate it.
Thank you.
All right.
Bye.
All right. Take care.